Today we will be focusing on venous leg ulcers and the importance of early assessment and intervention for long-term success. This seminar is supported by BSM Medical and contact information will be available at the end of the presentation. At any time during the seminar you can submit a question by commenting on the video and I will do my best to answer as many of your questions as possible at the end of the presentation. We'll now move on to the presentation entitled Venous Leg Ulcers, Importance of Early Assessment and Intervention for Long-Term Success. A venous leg ulcer, as we know, can be defined as an open lesion between the knee and the ankle that occurs in the presence of venous disease and takes more than 2 weeks to heal. And we know there's a plethora of evidence to support that. Julian Guest et al. And the burden of wound care study that he undertook has helped us also to highlight the impact of venous leg ulcers, not just on the economy, but the patients themselves. In the UK, 2.2 million wounds are treated each year at a cost of 5.3 billion. That's higher than the treatment of caring for patients with obesity and associated problems. The study also estimated, and remember it's an estimation, that there were over 278,000 people in the UK diagnosed with a venous leg ulcer. And at any point as well, over 730,000 patients with a lower limb wound, and only 278,000 of those were diagnosed. What startled me when I read a lot of this work was that only 16% of those patients with a venous leg ulcer had a recording of a vascular assessment. And we know a vascular assessment is so crucial for these patients. So it made me question what happened to the other 84% of those patients. Were they wearing compression and they shouldn't be? Or were they not having compression therapy and they should be? The results also indicated that 53% of those patients, only 53% of those patients achieved healing. So that's still leaving a significant number of patients with VLUs that are not healing. And we know that a non-healing VLU, or venous leg ulcer, I'll shorten it for this presentation, costs £13,500 a year compared to just £3,000 for a healed venous leg ulcer. What the study also indicated was the need for differential diagnosis, and I want to elaborate a little bit more on that. If we do not have an accurate diagnosis of the cause of that limb ulceration, how can we ensure that we have a very clear and focused and appropriate treatment plan for the cause of the limb ulceration? And that misinterpretation, that lack of diagnosis, can cause that chronicity and that longevity of that chronic wound. It also identified or indicated a need for shared management plans, and I think that goes across the board with all of the evidence best practice statements that talks about involving that patient alongside and engaging on that patient journey. And it also looked at that training was a fundamental element of wound management, and there were some issues around that. And again, we will elaborate a little bit more. There are various tools, many tools that can aid you, that can help your learning, that can help you in clinical practice. There's the best practice statement for improving holistic assessment of chronic wounds. The best practice statement for the holistic management of venous leg ulcers. And there's lots of tools, leg ulcer algorithms that can help and assist you with the correct assessment and management and selection of compression therapy, such as the leg ulcer algorithm by Atkin and Tickle. So there are a lot of tools that can assist you. One recent introduction which really excites me is the Legs Matter campaign. And I want to bring it to your attention. It's an organisation that's been formed to increase the awareness and understanding, not only for healthcare professionals, but most importantly for patients and their families. And it emphasises the understanding on the importance of lower leg and foot conditions. It's got really valuable advice and support, including help packs for clinicians, but also for the patient. It gives the patient a voice. There's a patient platform, and it really helps us to work together to improve that recognition of lower limb problems and prevent those leg ulcers. So I would encourage you to get involved. Also, lots of tools such as the case model that I'll be talking to you about that helps you when it comes to assessing not just the wound, but the case assessment for the lower limb as well. So cause, assessment, select and evaluation. When we look at leg ulcers, there are various etiologies, and tonight only allows me to concentrate very much on the venous etiology leg ulcers and a little bit on the arterial. The majority of patients that you may care for will be patients with venous disease, probably up to 70% of those patients. Arterial disease accounts for roughly about 5 to 10%, and there may be some of your patients that may have mixed etiology disease, so that's arterial and venous disease mixed. But there are very many other causes of leg ulcerations. There may be comorbidity associated problems such as diabetes. There may be other inflammatory factors or immunosuppressive factors that causes the limb to ulcerate, such as patients with rheumatoid disease or inflammatory bowel conditions that can lead to ulceration, such as pyoderma gangrenosum and vasculitis. But before we go along the journey of looking at the best assessment or most accurate assessment and management of our patients with lower limb problems, we need to have a clear understanding of the anatomy and physiology of the lower limb. It's crucial that we understand how it functions normally in order us to help to establish how to treat any underlying problems. So for the venous leg ulcer management, we'll be looking at the arteries, the veins, the valves, the calf pump, the arteriovenous coupling effect, and the normal venous return. We know with arteries, they supply the body with oxygenated blood from the heart. They have very thick elastic walls and can transport blood under really high pressure. And the following arteries supply blood to the limb. There's the femoral, the anterior tibial, posterior tibial, and the perineal. But damage to or removal of that artery can result in significant tissue death. And we already are aware that atherosclerosis, where we get deposits and accumulation of fatty materials in the walls of the arteries, cause plaques. We get reduced oxygen to the tissue, and we get tissue breakdown. With the veins do the opposite. The veins carry deoxygenated blood from the body back up to the heart. It's a low pressure, high volume system with thinner walls than the arteries. And the venous network comprises of deep veins, superficial veins, capillaries and perforators. These can become damaged or destroyed or removed during certain surgical procedures, but they don't normally lead to tissue death. The capillaries. These are the smallest vessels of our circulatory system, but they do a crucial job. They feed into the tissues of the body. They exchange oxygen, carbon dioxide, nutrients and waste between the arterial and the venous systems. So they act very much like the go-between. There's several litres of fluid are filtered by these capillaries every day, and the remaining fluid is then removed from the lymphatic system and returned through to the circulation. Fluid imbalance, however, can lead to edema. So when one or more of those circulatory functions are impaired, we can lead to edema. The valve function, particularly the valves and the veins, so we're talking about the veins here of the lower legs, operated by the calf muscle and the foot pumps on movements, and it's very much on walking or just those simple passive movements. So we have the opening of the valves. So when we dorsiflex and plantarflex our foot, the calf muscle contracts. It squeezes the veins running through them, increasing the venous blood pressure. That forces the valve to open and increases the blood flow, pushing it forward proximally. But then the valves need to close as well. So when the muscle relaxes, it causes the valves to close. And when functioning normally, the valves will then prevent the backflow of blood from the heart down into the venous system. However, if we get damage to those valves and the valves become incompetent, they will not close effectively, and we then get the backflow of blood down into the lower limb or the gaiter region. That can also be triggered by a decreased mobility, disease or trauma, and certainly venous hypertension. So when that occurs, we start to get this pooling effect in the lower limb and that raised venous hypertension. With the arteriovenous coupling, it's the arteries and the veins working together. They run in parallel in this perivascular sheath that you can see on your slide. And the pulse waves cause dilation of the artery, so just the pulsation, and in turn that causes a narrowing of the veins, and that is your aiding of your venous return. So it's important that they work succinctly together. And as I've just described to you, that is the anatomy and physiology of the calf muscle pump and aiding that venous return. But if some damage occurs within that anatomy, or if certain lifestyle circumstances lead to the inactivity of that calf muscle pump, such as reduced mobility, then problems can occur in the venous system. So let's look at case for looking after legs. What are our overall treatment aims for venous disease? I've already mentioned, and very rightfully so, we need that realistic plan of care with the patient. But that plan of care will not be beneficial unless we identify and treat the underlying cause. And I will keep taking you back to identifying and treating the underlying cause. For venous disease, we need to reverse that venous hypertension and encourage the reduction of the lymphedema, and that will come if we reverse that venous hypertension. We certainly need to treat the signs and symptoms. You know, a lot of my colleagues will say that they don't feel that venous disease or venous ulcers are painful. I was in clinic this morning and my patients tell me how painful venous disease is. It is a painful condition because of the raised pressure, the engorgement, the swelling to the limb, and that pain also and swelling can affect their mobility. It's also we need to ensure effective skin management, because with venous disease and raised pressure, it's a chronic inflammatory response within the skin and muscles that causes significant skin changes and limb shape changes. The ulcer is the last result of venous disease, it's not the cause. And that's important when discussing with your patients. Many of my patients who I see when their venous ulcer is healed say, great, the problem's gone away. And I start from day one and say, you have a disease, you have venous disease, and you will have venous disease for life. The ulcer is not the cause, it's the disease you have. And we have to start educating our patients to know that this is for life. Equally, the treatment aims include good wound bed preparation and wound management, and supporting the patient with education, advice, and involving them, and very much now aiming for that self-care involvement, and I'm going to share some examples of that. Because with that self-care involvement, remember that the high prevalence of venous leg ulcers will reoccur. With treatment aims for the arterial disease, I think it's quite simpler. We need that assessment, that specialist assessment, and immediate referral. We certainly need to manage the signs and symptoms, and again, I'll talk about that in a little while. But most importantly, it's important to work with the vascular team to hopefully try and restore the blood flow. But remember, if there's significant arterial disease, strictly no compression therapy. So why is it important to determine the cause? I think I've spoken at length about this, that it's really important to know what is the cause, but also not just the cause, what are the factors that might be delaying that wound healing? Okay, what are those factors? Because those factors may not just be simply the wound itself or the surrounding skin. There could be other intrinsic and extrinsic factors that can affect the wound healing. So if we can change some of those factors, we can encourage the wound healing. So for instance, simple things such as cessation of smoking. I call it simple because I don't smoke, but I understand that is a lot harder with some of our patients. But again, encouraging those changes, those intrinsic and extrinsic factors. Patients who don't want to go to bed at night or would prefer to sleep in a chair with their legs dependent, that's a massive contributor to edema and stasis of the blood. But again, if we can change that pattern, if we can change those factors, we can help to encourage the wound healing or limb improvement. So when we're assessing the cause, we're going to certainly with venous leg ulceration look at the venous hypertension, any venous incompetence, the general health of the patient, the medical history, are there any indicators towards that, lifestyle choices, psychosocial factors, and quality of life. And before you choose any form of compression, think about your patient themselves, and again, that desire to self-care if possible. You know, dexterity, mobility, and ability of the patient. So would we use, a hosiery kit compression system for somebody that had very poor hand dexterity if they wanted to self-care? Maybe not. So it's again addressing all those factors. The risk factors, time won't allow me to go through them all, but you can see there's various risk factors associated with venous disease. The simple ones being any presence of varicose veins, because that means there's damage to the veins themselves, whether they've been treated or untreated, previous history of phlebitis and DVTs. But most importantly as well, let's start thinking about the younger generation. Multiple pregnancies or just pregnancy alone causes increased abdominal venous pressure. That increased pressure also puts pressure on the lower venous system, and that then can lead to, and the hormonal changes can lead to problems with the veins or the valves. Again, maybe that's where we should start with our education and support. But there's various identifying risk factors. Of those, you can see quite a lot of them on your screen. With arterial disease, the risk factors are very much associated with the aging population because of the higher risk of atherosclerosis developing, smoking, hyperlipidemia, high blood pressure, all those factors that lead to that chronic inflammation of the vessel, of the arterial wall, that then causes scarring. Of course, there may be hereditary coronary heart disease and that atherosclerosis, but again, these are the risk factors we should be identifying when we're assessing our patient. So when we look at assessing the lower limb, it's really important that we look at various points. Whether it's venous and or arterial disease, we need to consider first of all the vascular status. What is the vascular supply like to that limb? The patient themselves, what are they telling you their signs and symptoms are, and what can you see? What you can see is normally on the patient's limb itself or the skin. So what are those skin changes? What are those changes you can identify that help you to make that assessment? And the wound itself. If we're looking at the vascular assessment, arterial disease, signs and symptoms, I can't list them all, but very much we look at maybe potentially a very poorly perfused limb. That limb may look quite pale, may be quite bluish in colour. There may be ulceration to the feet or the toes, or even necrosis of that area. There may even be some loss of hair due to the reduced oxygen and perfusion to that limb. Importantly, I listen to the patient's pain reporting. If patients are reporting cramp in their leg muscles when walking, or sometimes going up an incline or the stairs, that's a regular occurrence, and normally they'll report that they stop and they rub the limb and it resolves, but when they start to walk again, it returns. That's known as intermittent claudication, and that can be an indicator of early onset of arterial disease. If my patients are reporting resting on elevation, normally very quickly on elevation, not 3 or 4 hours after going to bed, but normally once the limb is elevated, they start quite quickly with a pain in the limb or towards the foot. It's normally relieved by them hanging the limb out of bed or resting with the feet or the foot on the floor, or even getting up and sitting in a chair. And that is an indicator that there is what we call a resting pain, and should be acted upon for assessment for arterial disease and referral on. You may say on the image that was shown, a patient with a very looking very red and well perfused limb, but actually on touching that limb it's quite cold, and once you elevate that limb that looks quite red, it's called dependent rubor, so when the limb is down it's quite red in colour, or sunset foot it's sometimes called, but actually when you elevate that limb it becomes very pale very quickly, and that again is an indicator of arterial disease. But one good way of excluding the presence of significant arterial disease, along with the holistic picture, is the vascular assessment. Okay? That also helps us to indicate if it's safe to proceed with compression therapy for your patient. It's the most common method that we use as clinicians to determine ankle brachial pressure index, or an ABPI or Doppler, some of you may know it by. But of course we need the ability to measure and interpret those results so that we can refer the patients on appropriately and speedily. And again, those further investigations, but always follow your local policy on that vascular assessment. But what you may also use is the classification of venous insufficiency using the CEAP guide. And CO is where there is no evidence of venous disease. Your C1 is where you might start to see those superficial spider veins, but this is a C1. This is saying that this is an indicator that there is some venous skin change, some venous changes going on, or some changes in the venous system. Okay. Your C2 is where you might see those superficial varicose veins or thread veins noticeable, but certainly becoming more noticeable now. Your C3 is where we are noticing a particular edema in the limb itself. Your C4 is where we start to see those skin changes, those pigmentation, discoloration to the skin. Here you can see that hemosiderin, that brown stain into the skin, is a result of long-standing venous disease with this raised venous hypertension, where the iron out of the red blood cells leaks and stains the skin. C5 is a healed leg ulcer, and the reason it's high up on that level is because, remember, the risk of reoccurrence. That skin has already been damaged, there's venous disease present. And finally, the CEAP guide 6 is with that open leg ulcer. So that's a really good guide to help you to grade and document your leg ulcer, your venous leg ulcers. But also we must be assessing the limb and the skin in a little bit more detail. So you're looking for those skin changes also associated with venous disease, and that might be venous eczema, as you can see on that slide. You know, that really dry, cracked skin that can become irritant. It can become irritant because there's enzymes and irritants that leak out of the skin that can cause harm to that healthy skin, and then it's that ongoing process, and that is quite common in patients with venous disease. You may see other indicators such as atrophy blanche, where we're having damage to the capillaries. Remember, we talked about the importance of the capillaries, so we're getting damage to the capillary loops, and we start to get this scarring and this white indicator of scar tissue on the limb itself. These are all things that you can photograph, you can document, and really help you to assess and identify venous disease. Here again, I'm talking about those skin changes. You can see in the images the hemosiderin staining, the varicose eczema that's become inflamed and irritable to the patient. You can see the limb shape changes, where we can see that large calf and the narrower ankle, and some of you may have read that as a being called an inverted champagne bottle. You've also got to assess, so remember we talked about the dorsiflex and plantiflex of the foot to aid that venous return. Think about if there's any deformity to the foot, any restriction to the mobility in the foot, or a fixed ankle. Again, how is that going to influence your choice of compression and encourage that venous return? But also think not just about all of the skin conditions, but that dry skin that is very much associated with that raised venous hypertension. That hyperkeratosis, where we have a thickening of the stratum corneum of the skin, so we get this waxy, dry, flaky skin that builds up, and it can range from a yellow to a brown colour, and it's quite distressing for patients to see that, and it's important we remove that hyperkeratosis and we add extra moisture back to that skin. And when we assess the lower limb, of course, we're going to look, if there is a wound present, examine the wound. So you may use the time framework where you look at the tissue. So what is the tissue like in the wound itself? Is it healthy? Is it granulating and red? Is it healthy tissue showing that the wound is moving along the healing continuum? Or is it sloughy? Is the slough present, and what colour is that slough? Is it malodorous? Does that indicate then that there's some infection or inflammation? And most commonly, lots of venous leg ulcers will be colonised, and possibly the majority will have biofilm formation. It's reducing that colonisation, destroying those biofilms, that can help you to help the patient's wound to heal. Moisture imbalance. Is the exudate levels being managed? Okay, we need moisture, we need that moist wound environment to allow cell proliferation, granulation and wound healing. But is it being managed? We don't want a dry wound, but we don't want an overhydrated wound either. So look at that, how can we manage that moisture? And finally, the edge, it gives us a good sign. Are there any signs of overgranulation? Any factors that may be stopping the wound from finally closing? Is there a lot of debris or dry skin around that wound edge? Are we going to debride that and remove it? Are we going to apply emollients to that area? Or are the edges suspicious? Are they not retracting in. So do we need to refer on this patient for a differential diagnosis possibly? But that assessment of the patient's limb and the wound to me is ongoing. Certainly the wound at each dressing change, and certainly helps us to assess the progression or not of that wound. So we're selecting appropriate therapy. Again, we've talked about that clear plan, but that clear plan comes with identifying the cause. So identifying the cause, working in partnership with your patient. What are your patient's objectives? What are your objectives? Let's work together. Okay, determine the appropriate treatment options, what best fits your patient's lifestyle. And that's, I think, you know, we talk about non-concordance of patients, but really, are patients non-concordant if we haven't given them choices to suit their lifestyle? So certainly where compression therapy is an option. So that clear communication and realistic patient expectations. When we're looking at appropriate therapy, you've heard me to talk about the importance of treating the lower limb and the skin. And you can see on those images, we've got a really nice healthy skin, and we have an area of skin to the lower limb that's lots of hyperkeratosis, that really thickening layers, and you can imagine how irritable and distressing that can be to a patient. So if I was to come along and advise compression bandaging without addressing that hyperkeratosis, the compression would not be as effective, but equally the patient wouldn't be able to tolerate it. So they'd actually blame the compression therapy itself rather than we haven't addressed the problem with the skin. So we need to look at washing those limbs, and I know what it's like in practice. I was in clinic this morning, we don't have enough time, we don't have enough resources. But if a patient's presenting with a 2-year history of venous leg ulcers with hyperkeratosis and their legs are not being washed, how much time do we have to release to get that right? And that really is important. And then along with debriding, if we, you know, time is an issue, but equally there's lots of tools out there that can help with debridement. Really easy tools. The debridement monofilament pad is excellent at removing hyperkeratosis, cleaning a wound bed. It traps the slough and the debris into the pad, and there you go, you've got a simple and painless method of debriding. Do you need to be a qualified clinician to do that? No. Can the patients do that themselves, or the carers? Of course they can. You know, again, it's encouraging that self-care and empowerment. And then after that, we really need to put the moisture back and applying that regular emollients. And if there are any issues with such things as acute eczema, then we may need short-term steroid therapy. But again, educating your patients, that skincare and those emollients are for life. They're not just whilst we're trying to treat the limb. The wound care is effective dressing selection, again to meet the wound's objectives. It depends on what you are seeing and assessing with the wound. Addressing whether you require an antimicrobial dressing to reduce the bacterial burden and destroy biofilms. What debridement method are you using? You know, it really is important that that debridement is ongoing. Managing the exudate, as I've talked about, and if exudate levels are high, considering definitely the use of superabsorbent dressings. So again, finally, with your wound care, observing for clinical signs and symptoms. Now, we as clinicians probably know most of the clinical signs and symptoms of infection: spreading erythema, increase in pain, increased malodor to the wound itself. But does your patient? Your patients are your first indicator that something is changing in that wound. So teaching your patients, teaching their carers what to recognise for the early signs of infection. If we can treat it really locally, quite quickly, effectively with a good antimicrobial dressing and good debridement, there won't be any need for systemic antibiotics. And finally, compression is absolutely fundamental prerequisite of the healing of venous leg ulcers. And I've had many patients over 26 years of tissue viability specialist saying, oh, I don't need compression, I've healed my leg ulcer without it. But you can guarantee they've been going through that cycle of reoccurrence as well. But it is a prerequisite. It's really, really important that we apply compression therapy. It reverses the venous hypertension, controls the edema and any lymphedema that might be present. And there's lots of evidence to support that. We're applying a continuous force that's normally measured in millimetres of mercury, and what we're aiming for full therapeutic compression is 40 millimetres of mercury. And what that does is reduce the blood pressure in the superficial veins or the venous system, reverses that venous hypertension and forces the blood back up to the heart, where then the venous and lymphatic system can then ensure more oxygen and nutrients to that wound bed itself. So you're reversing all those signs and symptoms of venous hypertension. There are quite a lot of new tools in the toolbox now for compression therapy, and I'm glad to hear that. We have more choices now for our patients. Compression therapy options available can be your multi-layer compression systems, your short stretch 2-layer bandage systems, but now we have our hosiery kits compression therapy, and we have our wrap compression systems as well. So we have a lot more to offer our patients. Before applying, or rather than applying, before selecting compression therapy, you really must, as we've said, assess the limb shape and size. So you're looking, if the limb is very distorted, large shape and size, then you may consider using compression bandaging before you go into compression hosiery kits to restore the limb shape, reduce the edema. And there are various really good toolkits out there that can help you when it comes to selecting on the shape of the limb, the size, and what to choose. And again, I have already mentioned the leg ulcer algorithm that was developed by Atkin and Tickle. So again, it's just a guide to you, but it simplifies, because we're all so busy, we really need to simplify venous leg ulcers. Whether you're bandaging below knee or the full leg, the leg must have a graduated conical shape for graduated compression to be achieved. And that again will be followed up with your training, the manufacturer's guidance. But what I will say is, when selecting a compression, always look on the patient's limb. Are there any areas that may be susceptible to damage? We are applying an external pressure, so look at any bony prominences, any muscle wasting, any areas that need to be built up. So extra padding is necessary there, and that's one point I will mention. I've mentioned the multi-layer compression bandage system. The aim is, with multiple layers of bandaging, again, to revert and reverse that venous hypertension, giving that 40 millimetres of pressure. You may have been advised to apply reduced compression in some of your patients, but that's normally under the advice of a vascular or leg ulcer specialist or tissue viability specialist when there is some arterial disease. But really, patients with venous disease, we are aiming for that full therapeutic compression at all times. Short stretch bandages, that's normally a 2-layer system, slightly different than the multi-layer compression system, made from 100% cotton, and when pulled, they stretch very little when pulled, applied at full stretch. But what they do is actually apply force to the calf muscle, forcing the blood back up to the limb. But the pressures here are lower when the patient's resting and higher when the patient is actually moving or using passive movements. So some of our patients like this system, particularly with the lower resting pressures when they're resting in particular. But again, it's another choice, it's another option for your patients. What I got excited about was the introduction of 2-layer stocking system compression option. And this isn't for prevention of reoccurrence, it's actually for healing of venous leg ulcers. Again, it's a liner and outer stocking, where you then, with the combination of the two, get a 40 millimetre of pressure at the ankle, so full therapeutic compression. It's suitable for leg ulcer management and prevention though. So lots of my patients who we've healed their leg ulcers in this system have actually then continued to wear it as a prevention, because they're used to it, they can apply it more easily, and they're happy with it, they're confident and concordant, and it's a really good self-care option. So you can imagine, you know, whatever your age, you know, if you can have a hosiery kit like this as opposed to bandaging, you know, patients have reported to me, I feel more normal, I can wear more normal shoes, more normal clothing, particularly ladies, I can wear a dress and a skirt. It's those little factors that mean an awful lot to the patient themselves. They can shower, again with assistance maybe, or not, and it just really gives them more empowerment. And then the wrap compression systems. Again, this is a really valuable aid in the management, not just of chronic edema, venous conditions, but lymphedema as well. So, you know, we're using an alternative to bandaging here, and we've got the multi-layer garment that works very much like a Velcro system around the limb. Again, how much easier, quicker and safer is that to apply? You know, very much compression bandaging normally has to be applied by somebody who's been trained and skilled in that area. So here with systems like this, carers, the patient themselves, think about your own skill mix in your team. You know, we can then use all of our team members to care for our patients with venous disease, not just the qualified team members. And it can then free up some time. It's much more quicker to apply, that we can free up time, that when we talk about not having time to do that holistic skincare, and it helps us to free up that time to do that in our already busy schedules. But let me end by sharing 2 case reports with you. They're not my case reports, they're colleagues who have used different forms of compression therapy to help their patients, and I'm going to share them with you. This was from a colleague, Jane, and as you can see on the screen, Jane had a referral of a patient who's 92-year-old lady. She's got bilateral leg edema, as you can see, and on and off over many years, that intermittent ulceration. She was reluctant to wear compression hosiery, and she found the bandages really uncomfortable. And this is a lot to do with past experience. She found the bandages dug in, or the hosiery caused you know, problems behind the knee, and I'm sure you've all heard that before as well. She didn't equally, I mean, and I love this about this lady, her words, she didn't want to be a burden on going for clinic appointments and on attending to see the nurse, or the nurse to come in to see her. What she wanted was her carer to be taught how to change her dressings and manage her limbs. She was a very independent lady and liked to socialise, and that is not wrong, irrelevant of age. At first clinic visit, Jane noticed obviously the bilateral leg edema, the shape was distorted, there was a large circumferential leg ulcer. On vascular assessment though, ankle brachial pressure index was normal, and what we mean by that is it was safe to apply compression. She had no significant arterial disease, but she had got some deep venous reflux as well. Due to a past poor tolerance of compression, again, and that was only through that understanding, through the clinician-patient relationship, she, with good conjuling, I'm sure, on Jane's part, she agreed to try that reduced compression in the form of a 2-layer short stretch system. And I know I said reduced compression really should only be for mixed etiology, but if that's the only thing we can start with, then start. You know, and then work your way up to full therapeutic compression. She's got a high level of exudate, so the clinician introduced a superabsorbent to absorb that exudate, reduce the bacterial burden, and that was the Cutimed Sorbian sachet. Clinic first visit the following week, the edema had already started to reduce, and bear in mind that was reduced compression. Okay, exudate volume had started to decrease, and just in a week the ulcer was smaller. She was still adamant though, she did not want to be dependent on professionals. She didn't even want to see the professionals once a week. She wanted to be free of that and wanted her carer to be taught. So rightfully so, using the concepts of what compression therapy was available, the team thought differently and said, right, okay, she wants this concept of self-care, so let's look then at the wrap. A wrap garment that the carer can apply, that can be readjusted if necessary. The patient themselves can shower, bathe, the skincare can be every day, twice a day, and so the clinician, Jane, put in the Job Sparrow wrap garment. Now they actually went for the light because of her low tolerance to compression, but just after 2 months of her first initial visit, as you can see on the picture, the ulcer had almost healed, very little exudate, and her skin condition had improved. But most importantly to me, it was her quality of life was dramatically improved. And I know it's quite frightening sometimes to say it's okay for the patients to dress their own wounds and to care for their own skin and apply their own compression, or the carers to do it, or the family members. But I think it's absolutely vital that we embrace that. Final case study is a colleague of mine, a colleague and a friend of mine, Leanne Atkins' case study, and it's a leg ulceration without edema. This patient was a 36-year-old male patient who presented, as you can see, with multiple ulcers, and you can imagine the quality of life, the negative impact on the quality of life of this patient. He'd had these bilateral ulcers for over 14 months. Now, he had got a previous history of IV drug abuse, and he had had a DVT to both legs as a result of injecting. So we know the deep veins are damaged now. We know there's going to be a compromised venous system. He's a young chap, he's married, he's got children, and this is very much impacting on his quality of life and his role as a father, and I think we take that for granted. He's tried various compression bandaging, but again, he's got a chaotic lifestyle. He doesn't always want to attend the practice to have dressing changes, often misses appointments, and again, due to those lifestyle, and it's important to know what the patient's life is like. Of course, the goal of treatment for Leanne was to reduce the volume of exudate and promote healing. That is our main objective. The objective for him, though, as a person, was to try and make his life as normal as possible. So it was agreed that because of the wound bed itself, and you saw that sluffy, high level of sluffy tissue, potential biofilms and microorganisms, that an antimicrobial hydrofiber dressing was used, and then an adhesive board of foam. And the reason for that was so he could self-care. And then Leanne chose a hosiery kit, and she used the Jobs Ulcer Care hosiery kit. It's a liner and a sock on the top. But again, the patient can do that for themselves. And even just following the first and second reviews, there was considerable improvement. Now, mainly, first of all, in the decrease of the exudate volume. But if we decrease the exudate volume, then the microorganisms will decrease, and so will the smell. And that was the most important thing to him, was the smell. You can imagine that to him is a husband and a person and a father. And then subsequently, the wounds went on to heal really, really well, continued. But this is him self-caring as well. So the clinician, or Leanne, or the team, was there as a supervisory support and capacity, rather than delivering all of the care. But it had a considerable impact on a positive outcome for him. The wounds went on to heal. He was happy to wear this garment. He was happy to carry on with that. And most importantly, what he said is he could still do all the things like the school run and all the other activities that impeded him when he had bandages on. So in summary, we do, and hopefully all of us understand, that venous leg ulcers have a significant impact on a patient's quality of life, you know, not just on their quality of life, but on their personal life, their social. Many of our patients become isolated and depressed, and the psychological effects of living with that venous leg ulcer for that period of time. It does have considerable financial impact. I've shared some of that data with you, and we are aware that there are huge impacts on that. But chronic wounds bring a higher risk. So these chronic venous leg ulcers are going to bring that higher risk of increased bioburden, infection and biofilm development. So by really, really early intervention, before the patient develops an ulcer, as soon as we start to see those skin or limb changes or edema, we need to act, and we need to act quickly. And there are lots of tools, as I've talked to you about, and many more out there that can assist you with that. Let's make it simpler for us and make it easier for us to implement the right treatment. And as I've said, for healing to progress, we're not just looking at the wound, we're looking at the patient, the vascular supply, the skin, and the wound itself. So in summary, lots and lots of tools out there that you can use. You know, I've mentioned some already: the best practice statement for improving holistic assessment of chronic wounds, the holistic assessment of venous leg ulcers, the case model as well. But again, if you want further information on that, don't hesitate to contact us, and we can supply you with that. There's lots of free education. Some of you may have colleagues who couldn't make tonight's live Facebook. This is being recorded. They can carry on and undertake this over the next few weeks or however long. But there's lots of other good e-learning, free education academies out there. BSN offer lots, and again, the details are there, and we can share that with you. Move on to our real-time question and answer session. Remember, you can take part at any time by commenting on the video. So we'll move on to our first question. Should you use emollients to treat hyperkeratosis? Yes, you should. As I've said, that hyperkeratosis is that thickening of the skin layers that will cause that really, really waxy feel to the limb. And with venous hypertension, that is a risk of hyperkeratosis or even just dry skin. So as well as debriding and cleansing and removing that hyperkeratosis, it's then important that we put the moisture back with those emollients. Again, use your local formularies to what emollients you use, but equally it's educating the patients that when the limb is healed, that is for life as well. So hopefully that's answered that one. Right, next one. What is sunset foot? Sorry if I didn't have enough time to elaborate on that. Basically, with arterial disease, of course, there is a narrowing in a artery or various arteries. So there's a demand for blood to the lower part of the limb. And what happens is when the limb is dependent, so it's pointing to the floor or on the floor, there is some force of gravity, and this is in a nutshell, so I'm sorry I haven't got a lot of time to elaborate on this, but there is some force of gravity that allows the collateral blood supply, so the smaller vessels, not the major vessel that's narrowed, to allow some blood down to that lower part of the limb. So it's really overcompensating for the narrowing in the artery. And what that then sometimes causes is this rubor, this reddening effect to the lower part of the limb. But actually when you feel the limb, it's quite cold. And when you then elevate the limb, hence we haven't got the force of gravity once the limb is elevated, it becomes very pale, and the colour then goes from this sunset foot or rubor effect to a very pale whitish effect. So hopefully I've answered that one okay. Are there any initial indications to recognise venous leg ulcer risks? Oh, I don't know if you mean by that. So again, I hope I can always elaborate on this after the event. Initial indicators to recognise venous leg ulcer risk could be with the patient. So it could be that the patient's had a history of a DVT, certainly multiple pregnancies. So I'd look at factors for the patient. Have they had any surgery that may have caused damage? Is there any trauma? Other risk factors could be their occupation, if we're standing for long periods, or certainly driving for long periods, the stasis of the blood, sitting for long periods, are we then at risk of stasis of the blood or even potentially damage there? So there are factors, whether you can visualise those factors. So certainly I am terrible for looking at people's legs, so I do apologise. And for my partner Neil, when we're on holiday and all I'm doing is visualising people's legs at the side of the pool. But there are clinical signs, yes. You can start to see if there are any varicose veins, varicosities, thread veins, discoloration to the limb. And what I didn't mention and really want to mention is that these patients should, gold standard, these patients should be referred on to the vascular teams. Surgery is an option here for some of these patients, and a real good option. And what we're trying to do is treat the disease. We're not treating the ulcer, we're treating the disease. So hopefully that's answered. I apologise if it hasn't, but by all means we'll be answering these over the next 24 hours. Oh, you're really testing me now. I could probably think this is one of my colleagues asking me this. If someone refuses compression, what treatment plan would you suggest? That's happened to me recently. It probably happens to me 2 or 3 times a week where patients are refusing compression. I know it sounds really simple and idealistic that, let's start and see why they're refusing it. You saw 2 case studies there that talked about non-compliance with the patient because of their past experience. So let's just try and find out, is it their past experience, the poor past experience that's made them say absolutely no compression? Do they know about the different options of compression? I do carry around with me in our clinics an example of, bandaging, hosiery kits, wrap systems. Let them look, let them see. Sometimes, if they refuse, they refuse. You can't enforce it, but don't give up. It has to be an ongoing process with these patients. Direct them to the Legs Matter campaign. Let them listen to other patients rather than you, because sometimes it's like you're the clinician and they're listening to you. If you've got local leg groups, leg clubs, encouraging them to attend that. There's no ideal solution, but really if compression is necessary, you've just got to keep working with them. And like in the lady's case, she started with that reduced compression, and I'm not saying that's always the first choice, but sometimes it is a choice, and she still moved on, but always with that clinician Jane aiming to get that full therapeutic compression. Can patients with diabetes be treated with compression bandages? Yes, they can. As long as we've established there's no underlying arterial disease. So that comes with your vascular assessment, and you know, what I will say with your vascular assessment with your diabetic patients though, sometimes you will not get a really accurate ABPI. It may be because there's some calcification, and I think this is going on to my next question as well. Sometimes there's some calcification due to the underlying diabetes or peripheral vascular disease that when you try and compress the vessel, you can't, and you get a reading greater than 1.3, which is my next question. So it's really important you start to look at toe pressures then and measuring the oxygen pressures within the toes. And if you can't, guys, because I know we've all got different skills, then refer these patients on. Refer them on to your vascular team, refer them on to your vascular nurse specialist, refer them on to your tissue viability nurses, because if they can have compression, they respond extremely well. And let's remember, the diabetic patients 4 times at risk of peripheral vascular disease, so these are the ones we should be undertaking the vascular assessments with. And my next question sort of links in with that says, how are we supposed to manage patients with an ABPI greater than 1? Again, I'll refer you to different Legos algorithms, but you can look up the one that myself and my colleague Leanne formed. The Legos algorithm, it talks about the elevated reading of 1.3 and above. Follow your local policy because it may differ, but what I will say is 1.3 and above, I think we panic a little bit too much about 1.3 and above, but again it's saying we cannot compress that vessel, there may be some calcification, so you go back to your assessment or you refer that patient to a team member who has more experience maybe in a vascular assessment. What you're trying to establish is there any high risk factors that link that patient to arterial disease or not, and you're just trying to rule out that there isn't any arterial disease. You may then look at oxygen, toe pressure, and again get further advice, is it safe to compress this patient? A lot of patients that I get a lot of referrals from clinicians just wanting that support. We have an elevated 1.3 reading, can we compress? But what I will say that also I will ask lots of questions around the whole patient assessment, not just the ABPI. The ABPI and the vascular assessment is part of your assessment process. When measuring the ankle circumference, when deciding how much compression to apply following a Doppler, do you measure the ankle? Oh, now somebody's definitely testing me. Do you measure the ankle before or after applying the wool layer? Again, there are different arguments of this if you read different various articles. I would say I tend to measure before applying the wool area. And I'm sure now whether the Facebook questions are going rife, but I tend to measure before I'm getting a true ankle reading there, as opposed to when I've padded out that ankle. Again, you know, that's my opinion. Is it common practice in some areas to start reduced compression before an ABPI result? Yeah, there is some evidence to suggest that you can put up to 17 millimetres of pressure onto a limb before undertaking an ABPI. That's recognised in the best practice statement. I will say with confidence though, you know, it isn't just about not doing the ABPI. Please make sure you've done that thorough assessment of the limb, the skin, the patient themselves and the patient history. So yes, it's, I'd say, is it common? I'm not saying it's that common, but you can do that. But again, making sure you've got that real, clear, holistic assessment and, you know, evidence to support that. Should we all be wearing support stockings? Really excellent question. So I want to know, I can't see who asks these questions, but I will be looking out for who's asked that. I would say if our lifestyle, if our predisposing factors mean we're at a higher risk, yes, we should. Certainly clinicians, we're on our feet, you know, I'm not saying we never stand for long periods, but if we're at risk in the sense of, do we suffer with edema towards the end of the day? Have we got noticeable thread veins, varicose veins, swelling, any other skin changes? Have we got any other risk factors? Then yes, we should. And I certainly feel we should be educating and supporting our mums to be in wearing some sort of support and compression. Why is there little emphasis on nutrition for wound healing? As this is something patients can control of themselves. Yeah, I can agree with that. We in Shropshire have formulated a sort of a document that helps for patients to say how can I help my wound to heal with my food or my diet. I think I agree. I think there's lots more work we can do with our patients on nutrition and wound healing. I think we do have that talk around, are you eating well? You know, are you drinking plenty of fluids? But actually, what does that mean to us? Are we actually unpicking what their nutritional status is like? And some of my patients, and I'm sure others out there will say, if a wound is not healing, the first thing I do with my patients is get them to keep a food diary. Because a lot of my patients will tell me they're eating lots of vegetables a day, etc., etc. And I know probably that may not be the case. They could write in a food diary that they're eating that, but it allows me to engage in that conversation. If a patient with a venous leg ulcer has had that ulcer for a long period of time, or it's a large ulcer for a short period of time, they will be losing a lot of protein and nutrients, and I agree with you, out of that wound. So very much maybe their serum albumin and protein levels are dropping and various other factors. If we don't increase that level of protein, then that wound will be slow to heal. So I think that's a fantastic point to make, and I think there's a lot more work to be done in that. But again, engaging with our patients on discussing about why it's important to eat well and drink plenty of fluids to encourage that wound to heal. Is discoloration of the toenail alone an early indicator of venous disease? No. I don't know what you mean by discoloration, whether it's a necrotic or just it's discolored. You could get discoloration of the toenail for various reasons. It can be trauma, it could be due to an infection, it can be due to a fungal infection, it could be due to a general condition. But I would not say it's an early indicator of venous disease. If anything, if I start seeing discoloration to toenails or toes themselves, alarm bells start ringing for me, more an early indicator of potential arterial disease. What would you, I don't know if that's been written out right, but what would you something for a very small ulcer on the outer dorsum of the foot? What would you do? Thank you. For a very small ulcer on the outer dorsum of the foot. I know it sounds like I'm repeating myself, but go back to the beginning. What has caused it? Because yes, there's an ulcer and it's small and it's on the dorsum of the foot, but something's not allowing that ulcer to heal, is it? You know, so I would start thinking clinically in my own head. Could it be something as simple as the footwear? And I know that sounds really simple, but it could be. Okay, what's the patient wearing? He might come in a really nice pair of shoes and refuse to change out of his shoes all day. And this happened to a colleague of mine, Gemma, whose patient had a wound to the foot, wearing very tight brogues day and night, well, not actually in bed, but long periods of times, wound to the, very much similar to what you're saying, wound to the foot, non-healing despite a really, really good assessment and robust treatment plan, down to the footwear. But could it be arterial disease? So is that linking to it? Could it be any underlying bony involvement? So osteomyelitis or any changes there? So always finding out, but simply find out the cause if you can. You may not always, but really good wound assessment and management, which we've talked about, and maybe offloading any pressure around that area as well. This concludes the seminar, and any questions we haven't been able to get to, we'll be answering over the next 24 hours. I'd love to take this opportunity to thank our sponsors, BSM Medical, for their support of this event. And again, all of their educational resources and contact details can be seen on the screen. And I hope this has helped you gain a better understanding of assessment, management and prevention of venous leg ulcers in just a short space of time.